I have some disclosures, none of which are relevant for this talk and will be found in the program. So a case example, 68-year-old woman with low back pain, 50%, and radiating leg pain, about 50%, right equals left, presented to our clinic. The back pain was largely axial in nature. The leg pain was radicular, both on the right side, anterolateral thigh, left side, lateral thigh, medial calf. Past medical history of hypertension, hyperlipidemia, and COPD, and some past surgical history of prior decompression at L4-5 and a prior ACDF of C4-5. So she had failed extensive non-operative treatment, several months of physical therapy, multiple epidural injections. The exam was 4+ out of 5 in the right quad and 4 out of 5 in the left TA. So just a small amount of weakness. Here are her radiographs. On the AP and lateral radiographs, you can see that she has a antalgic posturing, inflection extension, no gross instability, but a small spondy at L4-5. Here is the MRI of the lumbar spine. So on the MRI, again, we can see that at L3-4, there's a small retrolisthesis, L4-5, small anterolisthesis, and a fair amount of facet hypertrophy and degenerative changes along with that. On the right lateral recess at L3-4, there's a good amount of stenosis, and at L4-5, bilateral lateral recess stenosis as well. Here are her CAT scan cuts, which are relevant. So L4-5, grade 1 spondy with a vacuum air sign. And L4-5, you can see the degenerative changes in the facets, and then L3-4. And interestingly enough, I think I always like to look at the coronal pictures on the CAT scans because I find them to be very helpful because they essentially showcase in this scenario asymmetric disc collapse at L4-5 with the osteophyte formation, as well as at L3-4, there is a little bit of a lateral disthesis. That to me is pathognomonic for the pain generator. So really, really important to look at that. When we look at our MRI-L spine in the parasagittal cuts, you can see at L4-5, there is a large foraminal stenosis on the left side, and then at L3-4 a little bit on the right side. Segmental analysis. It's important to think about PI-LL mismatch, even if you're not doing a deformity case. And the reason is, as one of my mentors says, you're either treating deformities or creating deformities. So really important to think about this. So pelvic incidence in this case was 60 degrees. L1 to S1 was about 40 degrees. So that means that L4-5 only has about 1 degree of segmental lordosis. In other words, it's really lacking the necessary lordosis. And from L4 to S1, the lordosis was about 20 degrees. So in other words, a gross PI-LL mismatch as a result of degenerative disc disease here. So just like any normal spine case, instead of having one treatment solution or two treatment solution in spine, you get to pick a menu. You get to pick from many different options, and depending on your philosophy, depending on your way of approaching problems, you can pick between many of these options, which may in some ways address the patient's symptoms. So common options include laminotomy for aminotomy bilaterally at L3 to 5, which would be reasonable except for the fact that she has a fair amount of axial back pain. So that won't really address that. But that would affect the neurodecompression appropriately. Laminectomy with a posterior spinal fusion L3 to 5, that would probably be the most common treatment around the world in terms of how people would go about approaching this from an all posterior approach. Then one could consider augmenting the fusion with a TLIF operation at L4-5, especially because of the vacuum disc sign. Some people may consider doing a TLIF at both levels, 3, 4, 4, 5. Some may even consider doing a MIS TLIF from L3-4 and L4-5. I do a fair amount of MIS surgery, but my concern with MIS TLIF at 2 levels is the fusion rate. Then some may consider doing antero-only surgery, L3, 4, 4, 5. Again, it's a good option, but without posterior fixation, the question is about fusion and stability. Lateral only, L3 to 5. Endoscopic decompression is quite popular in Asia, and in India, many may consider doing this endoscopically, but again, it really won't it won't be able to treat the axial back pain component of the case. And then, the other options are doing a flip case, either doing a anterior surgery from 3 to 5 and then flipping and then doing a prone, and then alternatively doing a lateral flip where you put the patient in a lateral position first, do lateral interbodies at 3, 4, 4, 5, and then flipping the patient to a prone position. Or finally treating with observation, say, okay, we're going to send you to pain management and try more trials of those. So this is what we did. We did a simultaneous anterior-posterior fusion that consisted of 2 components. So the anterior fusion was a OLIF approach. So we did an anterior to source approach from L3 to 5. while the patient was in the lateral position. And then simultaneously, we did a posterior fusion from L3 to 5 with robotic assistance. And essentially what we were able to accomplish using this approach was L4 to S1 segmental lordosis of about 32 degrees. The intubation extubation time was 140 minutes, so about just over 2 hours, less than 100 cc's of EBL. Patient was able to go home on post-op day 1 and had 100% resolution of leg and back pain. And this is for those who are not familiar with how to put screws in a lateral position. So this is a patient in the lateral position. And as you can see, we are using a robotic device to essentially guide screw placement while simultaneously performing the anterior component of the surgery, which is anterior OLIF. So the patient is open up from both the front and the back. So using this technique, we were able to really very powerfully accomplish anterior posterior fusion in a single position scenario. So what is the goals of lateral surgery? Well, they're really the same as open surgery. The goals are to decompress the spine, stabilize and fuse the spine, and avoid creation of deformity. And the additional goal is to reduce iatrogenic trauma and recovery time. So, some principles, kind of the traditional original described principle was a retroperitoneal transpsoas approach, also known as the XLIF approach. And then the newer modification, which is what I do, is the anti-psoas approach, or also known as the OLIF approach or anterior to psoas approach. So the goals are to indirectly decompress the neural elements, have a wide surface area for fusion, and really accomplish the goals of surgery. Again, just to kind of reorient ourselves. So instead of going from the traditional posterior corridor, the posterior lateral fusion or PLIF, or going from a transforaminal approach, we are really going in this anterior to anterolateral corridor. So anterior to the psoas muscle or directly through the psoas muscle. So the patient is usually in a lateral position, and we use a combination of either a C-arm or navigation-based device. We dock the retractors in an oblique position and perform the discectomy in an oblique fashion. And then finally, when it's time for implant placement, after all the disc preparation work is done, we actually perform orthogonal maneuver and do the implant placement in an orthogonal setting. So it's a 90-degree angle. So this is what it looks like intraoperatively. So this is the L4 vertebral body. This is the L5 vertebral body. This is about a 2-inch incision. And you see from that incision, you can actually get all the way down to the L4-5 disc space, have an excellent disc preparation, and able to perform the discectomy and place the implant. I would note that guidance of imaging is critical. It's really important to use either fluoroscopy or some kind of a navigation-based device if you're not familiar with this technique, because you want to make sure that the implant is placed appropriately in the appropriate place, both in the AP and the lateral view. A couple of key points about lateral access surgery. It's really important to understand lumbar plexus anatomy within the psoas muscle and understand that there is some variation, especially when you're looking at the L4-5 level. So majority of cases, the nerve is posterior, but having said that, there are some variants, about a quarter of the cases where the nerve actually comes more anteriorly. So it's really important to be cognizant of that and use neuromonitoring or other stimulation-based devices to appropriately account for that. It's also important to note that the oblique corridor may not be feasible in all cases. So in some cases, you actually have to go through the anterior aspect of the psoas fibers, and that's because about a quarter of the patients actually don't have a true oblique corridor because of the proximity of the aorta to the psoas. So essentially, this oblique corridor is actually non-existent. So very important to avoid vascular injuries and really be cognizant of that. It's important to also select the appropriate implant and think about where you're going to place the implant and how you're going to do it. So end plate collapse can be a real problem because that can result in subsidence. So it's important to essentially span the entire width of the apophysis. So end plate collapse is most associated with incomplete span as well as excessively tall cages. So if you put physiologically abnormal cages that are much taller than the adjacent levels, then that can be a problem. And if you do this right, this can actually be a very good surgery. So there is a long series from Richard Hines and his group. And what they found is that 137 patients, 340 levels, the subsidence rate was only about 4%, 3% rate of ileus, 3% rate of vascular injury. The vascular injury rate here in this series seems a bit high. We have, fortunately not have had that issue. And then they have had a CT confirmed fusion of 98% at 6 months. So really the wide surface area of the implant allows you to have excellent fusion outcomes. Here is another quick example. This is a 75-year-old lady, functionally much more limited, L3 to S1 prior fusion. And now she presented with this adjacent level degeneration with lateral recess stenosis, with, as you can see, canal narrowing, with neurogenic claudication. That was her primary issue. And after about a 30-minute operation, where we performed a standalone single position, just a lateral only surgery without any posterior fixation. She was able to go home the next day and is now completely pain-free, and her claudication was resolved. So it can be a very effective technique. So in conclusion, the goals of lateral surgery are same as that of traditional open surgery: decompress the spine, stabilize and fuse, and avoid creation of deformity. We can also do single position lateral with simultaneous anterior and posterior surgery with the help of a robotic device. And certainly a lot of opportunities here for development and innovation, and to see where this technology goes and what else we can do with it. And proficiency takes thought and practice. So I'd like to leave you with that, and thank you very much.